So, good evening to you all. I would like this opportunity to welcome you all to this interesting case discussion that today we are going to do. So, as we all know, Yashoda Hospital, every Tuesday evening, we bring forth interesting and relevant up-to-date topics and interesting case discussions, which we do every Tuesday evening. So, as a part of this scientific webinar, today we are bringing you an interesting case. So, what is that case, and what was the interesting points in that case management, and what are the clinical dilemmas that we have? And we'll have throw some light on discussion during this topic presentation. So let me introduce you the panelists. So I am Dr. Karthik. I am critical care head at Somajiguda Yashoda Hospitals. And the speaker for today's case presentation is Dr. Shiv Kumar. Dr. Shiv Kumar is a consultant critical care at Yashoda Hospital, Somajiguda. And to take through this case, we have an interesting expert panelist today lined up for you all. So our senior expert panelist, Dr. K. Ashok Kumar sir, who is a senior consultant hemato-oncologist and BMT physician at Yashoda Hospital, Somajiguda, will be helping us to burst some clinical dilemmas during the management of this case. And we're also going to be joined by Dr. B. Harikishan sir. So he's senior consultant physician at Yashoda Hospital, Somajiguda. So welcome Ashok sir, and welcome Dr. Harikishan sir to today's webinar. And we'll start the discussion with the case presentation by Dr. Shiv Kumar, and we'll go through the interesting points during our case discussion. Over to you, Shiv Kumar.
So good evening, everyone. I thank Yashoda Hospital team for giving me this opportunity. So today, our case will be on challenges we have faced on a burn case. So basically, burns always we'll think of how to manage the resuscitation, infection, and sepsis, and etc. But here we had a very different kind of challenge of just I will go forward so that you know about it. So basically, this is a burn case which we have severe thrombotic microangiopathy following tetrahydrofuran exposure. Okay, so as we go into the case, so basically this is a 27-year-old male with nil comorbidities with the occupation of as industrial worker. We had an exposure during at the workplace with tetrahydrofuran. So it is an industrial solvent. So he had burns involving face, right hand, right thigh, and left thigh. So initially he was managed outside hospital. They have done the resuscitation, initial resuscitation. They have done the wound care. They have done the collagen dressing. But what happened was progressively over the next 2 days, suddenly he developed drop in hemoglobin levels and thrombocytopenia with normal coagulation parameters, and also had one episode of melena. So because of all these issues, the patient was shifted to the higher center as they don't know what is going on, as there was hemolysis. Normally we see sepsis and all those things, but in this there was drop in hemoglobin, there was thrombocytopenia. So the patient was shifted here. So these were the lab parameters in the outside hospital. So on admission, he had hemoglobin of 16.6.
Sir, your slides are not visible, sir. Can you?
My slides, sir.
Sir, slides are visible, sir. I am not able to see, sir.
Sir. Done, sir. Done, sir. Okay.
Oh, able to see, sir?
Sir. Sir.
Yeah. So basically, on admission, the hemoglobin was 16.6, TLC of 20,000, platelets of 2.3, creat of 1.3, and total value of 3.1. But as the one day, second day, suddenly there was drop in hemoglobin of to 7.9, and there was drop of platelet to 17,000. So just we need to see what was happening, and as we see, there was indirect hyperbilirubinemia. So all these were the lab reports. So by this, he was shifted here to our hospital, Yashoda Hospital.
So,
okay.
What are the things that we would be like discussing at this point of time if we have this case, Dr. Shiva?
Yeah. So basically now we can see as there is sudden drop in hemoglobin and there is sudden drop in platelets. But there was one episode of melena. So there was can be a bleed, GI bleed, one thing because patient had melena and chemical burns. We don't know what was going on. But the main important point in this is there was indirect hyperbilirubinemia and sudden drop in hemoglobin with stable hemodynamics. So again, this comes out whether patient had any DIC, any sepsis, going into sepsis, causing hemolysis. So all these things were in our mind. So we had to, once the patient came, as I go for the second, as when the patient came to our hospital. So this was at presentation. The GCS was 15 and hemodynamically stable with normal oxygen levels and no respiratory distress with fever of 101. So, but however, on examination, there was greenish discharge from both dorsum of hands and there was rapid hemoglobin fall noted and dark urine was reported. So concern was mainly ongoing hemolysis. So our hemoglobin parameters were 6.6, again very low, TLC of 15,000, platelets of 22,000, creat of 1.7 and indirect hyperbilirubinemia with normal coagulation parameters. So this is the place where we were thinking of what was happening, whether it is sepsis causing DIC, because but the against DIC was INR, which is normal. But yes, again DIC because there was thrombocytopenia and TLC was very high, and also there was some greenish discharge from the wound site. So again going towards the sepsis. So for our first thinking in this case was around for DIC. So, so here just I want to ask Dr. Harikishan sir about like how can we go on whenever we get such case. So in our like ER. So because normally burns we get as sepsis and for full resuscitation. That is this is very irregular case to get like with low hemoglobin, hemodynamic stable. So how to go ahead with these such cases?
Yeah, thank you, Shiva. So we were all involved in this management of this patient. So alleged history of exposure to chemical burns. He had significant burn injury when he was referred after 2 to 3 days of initial management elsewhere with dropping hemoglobin, jaundice, acute kidney injury. So you did say there was some amount of green discharge from the burn wounds of the hands. So when I saw this patient, my initial impression was it's probably pseudomonal sepsis, uh, supplied infection of the burnt wounds uh, with DIC, so thrombocytopenia, uh, hemolysis secondary to DIC, and other organ dysfunction because of the sepsis per se. That was the initial thing that was going on in my mind. And just to be sure, I think we did ask for a malaria, anemia, jaundice, renal thing. Coincidental kind of thing we did ask for. But here the first initial working diagnosis was sepsis with DIC. I think he did have some melena, but the drop in HP was out of proportion to the amount of melena he had. So we were looking at uh, hemolysis also. I think he had an LDH value from outside also, which was high. We did, so obviously we would ask for LDH, haptoglobulin at this point of time to see if there is ongoing hemolysis. And if there is hemolysis, then we need to be looking at the cause of hemolysis. Is it just DLC or something else? So I would want to know the PTA, PTT fibrinogen levels as well, because if it is DIC, there should be significant coagulopathy, not just in terms of thrombocytopenia, but PTA, PT derangement and very low fibrinogen levels as well. That would be my initial line of thinking.
Yeah. We did do even procalcitonin, sir, if we are not wrong. We had a high procalcitonin also.
Yeah,
Probably
which
not
was
on the first day, but probably on the second day, I think. Yeah.
yeah,
It was high. Yeah.
it was high,
Yeah.
3.
3.
So, so as we said, so basically we have on the day we have transfused blood products transfusion was done, 2 PRPCs and 4 RDPs, as there was history of melena drop in hemoglobin. So initially we thought like better we transfuse the platelets and we improve the coagulation profile and all those things. But further bicytopenia evaluation was done as we have heard. So basically these were the parameters what we got. So on the day one, so he as his GCS was fine, 15/15 hemodynamically stable with normal oxygen levels and no respiratory distress and fever subsided, no melena with good urine out. So on this day, so when we have sent the labs, we have seen that hemoglobin was still very low of 6.7 post 2 PRBCs. And our TLC was 20,000 and platelets were 49,000 post RDP transfusion. Creat was holding on of 1.7 with same worsening of indirect hyperbilirubinemia with holding on INR. And as we said, procal was high, 4.99, which again going towards sepsis. And other things like retic count was high, immature reticular fraction was high. So as there is no production issue. So, and even we have sent the CPK as there was discolor, urine was very dark color. So we want to rule out rhabdomyolysis. So we have sent a CPK, which came to be 100, which is normal. So interestingly, LDH was very high, 4,652, again towards hemolysis, and myoglobin was negative. And cystocytes, we have seen it was 12 to 14%, which is very significant. So at this stage, so we had these multiple things like sepsis, as procal was high, initially presented with fevers, some greenish discoloration of wounds. So these are going towards sepsis. Second, again, there was hemolysis as hemoglobin anemia was persistent after PRBC transfusions with very high cystocytes. So again, now we had two things, hemolysis and sepsis. So now we need to differentiate why this hemolysis, whether it is sepsis induced or whether whatever it is. So again, here our management plan was still blurred because we don't know next what is the plan, because so here, so basically our laboratory pattern was, typical initial pattern was rapidly decreasing hemoglobin, platelets decreasing, LDH was markedly elevated, indirect bilirubin was very high, and peripheral cystocytes were there. So this pattern strongly suggests it is microangiopathic hemolytic anemia. This was there. So what next? So our differentials were first sepsis-induced TMA, then DIC, whether it is drug or toxin induced, or whether it is secondary TTP. These were our main differential diagnosis. So critical question again here was the main question where we had challenges, whether it is TTP or secondary TMA, as this distinction determines the therapy. Because it is life-saving in TTP, plasma exchange is life-saving. We can't delay. Within 48 hours, we need to do plasma exchange, or else the mortality was very high. And in secondary TMA, normally plasma exchange is not indicated or doesn't work. So here where we have involved our hematologist. So
Yeah.
hello.
It would be appropriate for Dr. Ashok Kumar sirs also to come into the picture. And when he was called into this case, there were multiple things on the hand. So what was your first impression, sir, when you saw this case? Dr.
Sir,
Ashok?
sir, my
Sir, your
first
video
impression,
is off, sir. Yeah.
sir, my first impression is one is sepsis with DIC. Second one is this one, sir, TMA. So it's a mixture of both, we can say, sir. TMA overlapping with with the DIC. So what we thought is, it is, though it is hyperbilirubinemia is there, it is not predominantly unconjugated, sir. But mostly it is a mixture of both, sir. Both conjugated as well as unconjugated. If it is like predominantly unconjugated, 80% should be unconjugated hyperbilirubinemia. It is here, it's almost like 50-50. So it's both sepsis as well as some amount of hemolysis is also happening. So we thought of DAC, some amount of TMA is also there, secondary to toxin or sepsis leading to TMA, something like that. So whatever may be the cause, the treatment, if it is frank DIC, in DIC we see cystocytes also. If I remember, sir, here I think PTI APT is also prolonged, no, sir, here.
1.7. INR was slightly, it was 1.5, then came
that goes a little against TMA, sir. So we thought it has mostly predominantly sepsis leading to DIC. Second is it could be TMA also.
So,
And
did you think
so,
about TTP, sir, at this point? Because
TTP are
all the
unlikely,
pentad
sir.
features are not there.
TTP, sir? Which features, sir?
All the neurological features, I don't think were there. But
nothing was there, sir. Yes, sir. And mildly creatinine is mildly elevated. That we can explain with so much of burns, dehydration, and all those things. So we can explain with that creatinine also.
Yes.
So what I thought, first we thought of sepsis with DIC, then probably secondary TMA.
TMA. Okay. Okay.
So So basically, we have done a plasmic score as whenever as a clinical intensivist, once we see any microangiopathic hemolytic anemia, we go and do this plasmic score and French score. So when we did this score again, it came to be very high, 7. And as to rule out DIC, we have done fibrinogen, which came to be more than 600 to rule out DIC. So again came plasmic score was 7 and French score was around 2. So again, which comes to very high probability of TTP. So I want to ask one thing, sir, here, Ashok sir. So what is the role of doing plasmic score and how we need to do, whether we need to do for all microangiopathic hemolytic anemias or where we need to actually do this so that we don't go into the wrong direction?
The plasmic score was initially it was discovered only in case of primary TTP, sir. That secondary to autoimmune diseases like where ADAMTS13 activity is very low. In that cases only we go for plasmic scores, sir. Not related secondary TTPs. We usually don't go for with plasma score.
Okay, sir.
Sir.
So that's what, sir. When I've seen many studies, what they have seen is actually the specificity is 55 to 60%. With especially and secondary TMS, it doesn't hold good. So
Correct.
I think whenever we use this plasmic score, we need to be very specific with where we are using it.
Correct.
We should
Correct.
not use in all things,
Yeah.
but whenever we are thinking of primary TTP, then only we need to use
Correct.
this, and
Correct.
or else we'll be just going in a wrong direction.
Correct.
So here we have went for a multidisciplinary team discussion. So basically, this chemical was a new one. Actually, we have tried searching many articles about this, but we did not get anything how to treat and everything. So we had multiple discussions with nephrology, hematology, mainly nephrology team, whether because as the chemical with many search and all those things, we have seen that it is a water soluble and smaller size. So we have had a discussion with Harikishan sir and also with the nephrology team whether we can do a dialysis in this, as it is a dialysable because it is water soluble. So we have done one session of HDUF so that if we can remove any, because in secondary TMA main treatment is to remove the source. So we have done these things. Then we have involved the hematologist regarding the secondary TTP versus toxin TMA, and surgical team, as sepsis was also there because there was yellowish discoloration of wounds. So we have involved the surgical team, that is a plastic surgery team. Dr. Sanjeev Shashmi was our team, the surgical team member. So he has done the debridement so that we can control the source, any sepsis source. And as a critical care team, we were seeing all the multi-organ failure risk and all those things. And Harikishan sir were looking over about the sepsis. So here, Harikishan sir, I want to ask one thing. So what about the sepsis and plasma exchange? Yes, no, and sepsis. What about antibiotics and all those things in at this point of this thing?
Yeah. So though our initial working diagnosis was sepsis with DIC,
Right.
the fibrinogen was more than 600. So we thought there was some other pathology going on, and that's what we've discussed. So there's probably some amount of infection, but he didn't have septic shock or no severe sepsis kind of thing. There was something else causing his problem. He had definite hemolysis, LDH was elevated, there were cystocytes, severe thrombocytopenia. So some form of thrombotic microangiopathy was considered besides infection. Uh, so the question was now, we don't know whether this toxin that he's been exposed to, it's such a rare thing. Literature, I don't, we have any literature saying that the toxin is associated with this kind of TMA. Digging into past history, I don't know if Dr. Shiva already mentioned, he had some thrombocytopenia a few months back with some low-grade fever, throat pain, 40,000 platelets, but which recovered within 3 days. So that's probably, it was not chronic thrombocytopenia. If we had chronic thrombocytopenia, we could have considered some underlying TTP, which worsened because of superadded burn injury or infection kind of a thing. Okay, so here the question was whether to do plasmapheresis, but he had burn wounds. He had some evidence of infection. He just had the debridement done. So, and the diagnosis was not very definite. So the combined decision was not to go for plasmapheresis, but to give him plasma. He had some amount of coagulopathy and bleeding from the burn wounds as well. So that's the reason we opted out of plasmapheresis, because he already had some amount of infection. We were worried if the sepsis would worsen with plasmapheresis.
So, so next. So so we have done a HDF with hemoabsorption filter was initiated along with FFP and PRBC transfusions. So basically, why this case is interesting was it was a tetrahydrofuran. The chemical was had a limited literature available. Ongoing systemic issues like hemolysis, AKI, sepsis, burn patient, multiple issues which were going on, and the case was mimicking TMA with TTP. So it was looks like some overlap thing. So we had some limited knowledge on pathophysiology of that chemical. Then we had to take an urgency on decision on definitive management, whether we need to do a plex or what to do next. And because based on this, the prognosis of the patient goes on. So, next day his GCS was fine, his hemodynamics was fine. Hemoglobin again it was 7. So creat was 0.9 because post dialysis creat was holding on. LDH was persistently high. Cystocytes were 13 to 15%, and INR was 1.6. So we have consulted hematologist Ashok sir, and we have started off daily FFPs. So, sir, Ashok sir, here I want to ask, so role of FFPs in this case, like we have transfused only FFPs for 3 days for hemolysis. So, role of FFPs in this case when we are not doing TTP plasma exchange.
Sir, whatever may be, even if you think of TTP or TMA, or if it is sepsis with DAC, our role is to keep the platelets more than 1 is 50,000 and fibrinogen more than 150, and then to maintain hemoglobin between 8 to 10. So because of all the associated complications, whatever the patient is having, we have not opted for plasma exchange just because he is having so very bad infection. We have to put the other line, all those things, and we are not definite to, there is no definite evidence to say that it is TMA. Except for that, because PT is little deranged, it should be normal in TMA. So what we thought is, whatever, even if it is TMA or it is sepsis with DSC, the treatment will be the same like FFP infusion. So we gave a trial of FFP at a dose of 10 ml per kg, which helped in this patient. Actually, if you on the day 1 of FFP, from next day onwards, his platelets gradually improved, LDH came down, bilirubin started coming down, creatinine also improved. Everything is going to set. So by the next day, we came to conclusion that we are in the right path. So we continued FFPs. It was our thought process. Not we can say any back evidence is there means I can't say that, but in the back of our mind, we are dealing with both the components of DSA as well as TMA. So better give FFP instead of going for plasma exchange. That's also.
Sir, two questions, sir. Here, since we gave plasma and we are seeing improvement of the platelets, do you consider this as a sign of toxin-related TMA, or could this be a toxin-related TTP also?
We cannot say, sir, like that. Sir, we cannot say, sir. Yeah.
Okay, sir. And one more thing, sir. In sepsis, if sepsis can cause TTP also, sepsis can also mimic TTP. If we have sepsis on our hand, if not for this case, is there any role of doing minimal plasma exchange and seeing for early platelet rise and stopping further sessions of plasma exchange? Is there any
No, sir. No, sir. No, sir. No, sir. If patient is in sepsis with DSC, we just give plasma only, sir, along with platelets. In case of if it is a frank DSC, there is no TMA, suspected TMA component. Our target is to maintain platelets more than 30,000 and fibrinogen more than 200. If it is a case of DIC. So we give FFP along with platelets. But if it is only TMA means we don't give platelets, but we will manage with only with FFP, sir. Until and unless patient is actively bleeding, then we will give platelets along with FFP, but not only platelets in case of, if it is a case of TMA.
Okay, sir. Yes. Well said, sir.
Harikishan, sir, anything from your side, sir?
Yeah, so that was the decision. So there was some evidence of hemolysis with cystocytes, saying that there is microangiopathic hemolytic anemia. This patient definitely had microangiopathic hemolytic anemia. He had thrombocytopenia and other organ dysfunction. There was some evidence of sepsis. So because he didn't have septic shocks, it was not looking like florid DIC. The fibrinogen was good. That's why we brought in the diagnosis of some TMA, some form of thrombotic microangiopathy. And then because of the coexisting infection, we decided just to give plasma and see whether but he did respond, whatever was his response, which time or he responded to plasma, because the moment we started giving him plasma, he responded. So generally drug-induced TMAs are antibody mediated. So for them, they usually require plasmapheresis because you need to remove the antibodies. But this patient did respond. We know that TMAs have a wide spectrum. The response also, the manifestations vary, the response to various forms of therapies vary, though we can't just put them into boxes. So this patient, looking at his overall picture, we kind of opted against pheresis. We didn't want the sepsis to worsen. And he did respond to the plasma transfusion that we gave him.
So as the discussion continued, so we have daily we have transfusion of around 10 ml per kg was continued. So as we have discussed, so as we have seen, the hemoglobin started holding on and LDH started coming down. So you can see it came down to 1699. Platelets starting holding on from 43,000 to 95,000 without any transfusions. And cystocytes, as you see, with 1 day of transfusion, cystocytes came down by around 3 to 4% from 12 to 15%. So there was drastic improvement after transfusion. So what we have done is we have done 1 more day of daily transfusions of 10 ml per kg were continued up to sir said, to maintain the platelets up to 95,000. So but during the course again we had some ups and downs, like a patient had desaturation on day 5. So after multiple because he required multiple transfusions, so desaturation requiring oxygen, then went into HFNC. So again we had confusion what was going on. So these were our again diagnosis for hypoxia. So whether it was chemical pneumonitis because he had facial burns. So second, there was secondary pneumonia or ARDS, or whether it is due to Charlie or TAC. So at this stage, we have done a CT scan to see what is going on. So the CT scan was showing basically bilateral lower zone, more of pleural effusions and pulmonary edema picture. So we have involved again nephrologist here and we have dialyzed so that we can remove the excess fluid. After that, basically, so oxygenation improved and patient got shifted to ward. So on day 7. So in ward side, again, the platelets. So once we have shifted to ward, then we have not transfused anything. So the platelets, hemoglobin and LDH were daily monitored there and showing uptrend. So as we see, the hemoglobin was showing uptrend 8.4, 9.2 and 10. And even LDH was decreased like 1545, and then this day 10 is basically the discharge day. The LDH was 848. So platelets again improved from 1.78 to 2.28. This is only by pure FFP transfusions and not by any flex or anything. So there was no further transfusion needed, and there is no progress, and there was progress improvement in urine output, and no further requirement of RRT was done after day 8. So once we have done the HDF for removal of toxin, and second is for fluid removal. So after that, once he has been shifted to what, we have not dialyzed. So say even patient came for follow-up after 5 days. I think Harikishan sir I've seen on 16th. So even his hemoglobin was 11.3, platelets were normal, creat was 1 and bilirubin was 0.9. So successfully we have treated this case without any plasma exchange by basically involving multiple departments and taking the correct decisions basically. it was a challenging case with multiple discussions going on, whether to do a plasma exchange again on sepsis, and whether again going for FFPs. Again, we had multiple discussions, because if it is a TTP, not doing plasma exchange again will cause a lot of issues. Okay,
Yeah,
so
but how was the doctor? Sorry to interrupt you, Dr. Shivkumar.
yeah,
How was the patient after review? I think Dr. Harikishan
yeah,
sir will
Harikishan
say.
sir has to tell us.
How was
Yeah,
his how was his wounds?
yeah, he's actually doing very well. 16th, yesterday only came to OP for a review. 1 week exactly. He got discharged on 9th, I think, and then he came yesterday on 16th. That was his hemoglobin. Platelets were normal. Creat was okay. There was no jaundice. He came walking. Uh, he's fine. His wounds are healing. He's not even requiring dressing for his burns now, kind of, you know. So he's actually doing very well. He's on very low dose steroids. So he'll be reviewing with us after a few weeks. He's going back to his native place. We've asked him to review after 2 weeks, but he'll come after. He wants to come after a month because he's going back to Bihar.
Okay, okay.
And one more
I,
thing, sir, I forgot to discuss about the steroid role in this case. So I think we have even started steroid for this case around 100 TID of hydrocortisone. So Ashok sir, so what is the role of steroid, as we are not seeing any antibodies in this case, more of chemical induced? So role of steroids.
Empirical.
Anything?
No, we just added. It could be TMA like that. We thought of no. So
Yeah.
just gave if there is any evidence of some amount of mild hemolysis is also there to decrease that. We have added a mild dose of steroid 0.5 milligram per kg. That's all.
Right.
Actually,
Yeah.
there was some pneumonitis also, if I'm not wrong, in the lung. So like that was also one of the reasons why probably steroids were added. Though yeah, so these are where some of the reasons where the consideration for steroid was taken.
So we will have some brief review about the chemical and about the secondary TMA pathophysiology. So that actually it was very difficult to search articles on secondary TMA, the pathophysiology, how it works. And so basically chemical burns, so constitute around 3 to 5% of burn injuries. So what is the main problem of chemical burns is they often cause disproportionately severe outcomes due to deep tissue penetration and systemic toxicity. So unlike thermal burns, where tissue injury continues until the chemical is completely neutralized or removed. So there are mainly two types, like strong acids and strong alkalis, which causes major issues. Okay, so strong acids mainly causes coagulation necrosis, and strong alkalis cause liquefactive necrosis, which is actually more problematic than acids. And common sources of strong acids are battery acid, towel cleaners, metal cleaners, and strong alkalis are drain openers, oven cleaners, and wet cement. So chemical burn should always be evaluated not only for cutaneous injury, but also for delayed systemic complications, which may involve hematological, renal, and metabolic toxicity. So we need to be always be careful whenever we get chemical burns rather than other burns, because they can cause a lot of systemic problems. So our topic of discussion was tetrahydrofuran. Basically, it is a cyclic ether solvent where it is used is normally polymer manufacturing, PVC processing, adhesives, laboratory solvents. It is where it is used. And mainly the mechanism is lipid solvent causes membrane injury, oxidative injury causing hemolysis, and it can also cause direct endothelial toxicity. Main potential effects, as we have seen, direct endothelial toxicity and all those things, hemolysis, renal failure, CNS depression, and rarely micropathic angiopathy. Actually, we have tried searching. There were only around 1 or 2 articles on this, which was showing like a patient had some renal dysfunction, liver dysfunction, which improved by itself. But they have never mentioned about hemolysis and all those things in that. Only liver and renal dysfunctions were mentioned. That was also very mild. So basically, what is microangiopathic thrombotic microangiopathy is basically it is occlusive microvascular or macrovascular disease, often with intramural thrombus formation, characterized by microangiopathic hemolytic anemia, which is characterized by increased LDH, basically hemolysis, increased LDH, increased indirect hyperbilirubinemia, decreased haploglobulin, and increased reticulocytes, and along with non-immune thrombocytopenia. This is again important. Coombs test we have also done, which was negative, and or end organ ischemia because of all the microthrombi. So mainly pathophysiology of secondary thrombotic microangiopathy. once we see, then actually what we have done giving FFPs was actually right. So basically what happens is the secondary TMA is mainly started by triggers like drugs, toxins, sepsis, infection, malignancy, transplantation, severe hypertension, and inflammations due to burns and trauma. So these are the main triggers. What does it does? It does endothelial injury. So it does endothelial injury by causing glycocalyx disruption. So this disruption, what it causes? It causes increased cytokine release and increased adhesion molecules like ICAM, P-selectin, E-selectin. So, and because of all this, again, endothelial damage and all this activates the complement. So complement activation, it again causes formation of membrane attacking complex. Again, it causes endothelial damage and this worsens the cycle. So once there is endothelial injury, what happens? Our body, it produces von Willebrand factor. So von Willebrand factor is normally produced as a ultra large multimer. So normally this Adam TS13, it leaves this ultra large von Willebrand factor to a small von Willebrand factor multimers. This is a normal thing. So what happens is in this secondary TMA, this there will be imbalance between von Willebrand factor and Adam TS13. Imbalance will be there. As in TTP, where there is deficiency of Adam TS13, here deficiency, it will be less than 10%. But in these condition, it is not deficiency but imbalance, because von Willebrand factor will be produced more than what Adam TS13 is available. So this imbalance causes the platelet adhesions. So this is the main pathophysiology of secondary TMA. So there won't be any antibodies production, or there won't be any destruction of Adam TS in this secondary TMA. So because of these factors, what happens is there is platelet adhesion and aggregation, forming microvascular thrombus. And because of this platelet adhesion, again there will be platelet-rich microvascular thrombi. And because of this microvascular thrombi, there will be organ damages involving kidneys, liver, lung, and all those things, and brain mainly. So, and whenever these RBCs flow through these thrombotic vessels, they cause hemolysis, causing, this is what cystocytes and all those things causing MAHA, that is microangiopathic hemolytic anemia. So this is the main pathophysiology of secondary thrombotic microangiopathic anemia. So based on this, basically pathophysiology, actually there is no role of plasma exchange in this secondary TMA. But yes, FFPs, yes, there is a role, because by FFPs we will be increasing the concentration of Adam TS13. So chemical exposure mainly cause TMA without Adam TS13 deficiency. So mainly mechanisms are, as I explained you, endothelial toxicity, oxidative stress, complement activation, and platelet aggregation. And triggers like chemotherapeutic agents. Mainly what I have seen is they have they have not given any chemical induced secondary TMS, but broadly they have given a lot about drug induced, mainly cancer related drugs, chemotherapeutic agents, calcineurin inhibitors, and industrial chemicals. So this is basically a secondary TMA. So why was this case very important? Like there was clear chemical toxin exposure, and there was burn related inflammatory response. But again, plasmic score, as we have done, was very high. Clinical improvement was there without plex. So this was the very important things, challenges what we have faced in this case. So suggesting secondary endothelial injury. So this was the thing: burn injury, cytokine storm, complement activation, endothelial dysfunction, and microvascular thrombus. So this is the major where we can get everywhere about this thrombotic differentiation between TTP, DIC, and secondary TMA. So main differentiating factors I will be explaining. So basically in these TTP and TMA, what we see is the PTINR and APTT. The coagulation profile will be totally normal, and in DIC normally it is prolonged, and fibrinogen will be decreased in DIC, which will be normal in TTP and TMA. And in basically in 3 of the diseases we can see hemolysis, that is cystocytes. And Adam TS activity will be less than 10%, that is severe deficiency in TTP. In DIC it will be normal, and secondary TMA it can be normal, sometimes mild or moderate reduction can be there. So in organ involvement, mainly brain more than kidney, and in DIC it will be multi-organ, and TMA it is mostly kidney. So the main first line of therapy of TTP will be urgent plasma exchange, and DIC obviously are treating underlying cause and blood products. And again TMA, mainly removal of the triggering agent. Whatever the agent is, we need to remove. So here what we have done in our case was hemodialysis to remove the chemical toxin. So treat the underlying trigger. So role of FFPs again. So what is the role of FFPs in these? So in TTP, wherever plex is not available and until unless you think like TTP is not diagnosed, we can use as a bridge. Only bridge or whenever plex is not available. And in DIC, yes, to correct the coagulation, and in secondary TMA as a supportive replacement, as I explained you the pathophysiology. So basically to increase the ADAM TS13 levels. That's it. So prognosis normally is excellent with early plex in TTP, depends on the cause in both the DIC and secondary TMA. So in our case, the management principles were mainly to treat underlying trigger, supportive ICU care, transfusion support, and renal replacement therapy as needed. So plasma exchange normally removes anti-ADAMS 13 antibodies. It replaces ADMA, TS13, and standard therapy for immune TTP. This is the main role. But in our case, it was secondary TMA, so we did not use this. So evidence in secondary TMA, again, plex benefit was very inconsistent, and most cases improve with trigger control, as we have seen this about this. And role of FFPs provides ADAM TS13 replacement and useful when TTP cannot be excluded. In this case, again, we had doubt about TTP or not. So again, that's why there are multiple reasons why we have used the only FFP in this case. So our management strategy was very clear. Daily FFP is 10 ml per kg body weight until the platelets improve. Renal replacement therapy, one to remove the toxin, and second for fluid overload, supportive IC care, and we have not used any plex, which was more complicated. So this was the many references what were there. Thank you.
So, yeah, as you have summed up, Dr. Shivakumar, this case presentation throws light on a complicated case scenario where sepsis complicates a condition like TMA or a sepsis complicates a condition like TTP. And how do we balance it both? And how do we get the best to any patient in bringing successful outcomes? So one query, Dr. Shiva, would Adams 13 was it sent, or why Adams 13 would not sent?
So basically, we have not sent because it was clear-cut chemical injury. So basically, we had a trigger which was showing it. So we have, as we discussed, so it was not clear-cut TTP. So it was more of secondary TMA chemical induced. So we thought like it was more of chemical induced secondary TMA. That's why we have not sent. But actually, we thought of sending it later because we have done more of transfusions and all those things. So we thought of sending later. Actually, Harikishan sir can come because actually we discussed about it. About the Adams, yeah.
Yeah, we actually thought of sending it, but I'm not sure if he received any transfusions also, I don't remember. But on day one, while these discussions were going on before, we could understand what was happening, he was transfused because of very low platelets and, coagulopathy, some bleeding. So once you give FFPs, I don't think we can send Adam TS levels because that will be altered. So we did not send it, but subsequently, now we may send it just to make sure that he didn't have any underlying TTP kind of a thing which was triggered because of this burns and then the toxin exposure.
So sir, one question for Ashok sir. So when to send Adams T30, whether it has to be sent to all cases of TMA or where actually we have to send it?
In primary, sir, in primary TTP only, usually if you are strongly suspecting a case of TTP, like primary, then we will send, sir. As we have discussed in one of the last cases, that young girl. On day one itself, when the patient is in ER, we told to save one extra sample to keep the sample and send it for RMTS 13. That is the high level of, you should have that high level of suspicion of that we are dealing with a case of TTP, then prior to transfusion support, anything, FFP, platelets, whatever may be, keep an extra sample because overnight, usually all these things happen in the night itself, sir. So we keep an extra sample on the day, then we start transfusing FFP, platelets, whatever. In this case, we just because by the time we came to know everything was transfused. So that's why we didn't want to send, because anyhow it will be high only. Then it's not going to help us in arriving at a definite diagnosis.
So, do
Even
we have
PRBC and
antibodies, sir? To Adam's antibody assay is done in India, sir? Do you know? Do you have any idea about it?
No, sir. Even in primary cases also, we don't do. Only we do the Adam TS13 levels only. Antibodies, whether they are doing it or not, we don't have any ideas. This Adam TS13 activity itself is doing one or two centers, sir, in all over India. So
Okay.
antibodies against to the even it is there, it is not going to help us, sir, because we are going to treat with if it is a primary case, we are going to treat with once we are removing the antibodies. Other side, we are reducing the. We are also doing B cell depletion by giving steroids and also rituximab. So both of you are addressing. The cost itself is very high, sir. I think if at all they are doing, it will be very high. This itself, Adam TS13 itself is like almost like 45,000-50,000, sir. So
Okay.
antibodies to that is even more high. It will be high.
And even takt time of Adam TS13 is, I think, around.
Yeah, correct, sir. 1 week, 10 days it will take,
Yeah,
sir.
it takes a lot. So until that time, patient will get discharged mostly. Yeah. So
No, I think plasmic score will help you in that situation. I think exactly to have high degree of suspicion. Yeah, but as you are saying, turnaround time is higher and cost is also higher.
yeah. So
Yeah. So, any closing remarks, sir? Dr. Ashok, sir, from this case, what are the takeaway points that you would like the people who are listening to this webinar should keep in mind if they come across such a case scenario, and anything specifically that you would like to tell to our attendees?
I think Harikishan sir will be telling, sir, more than me. He is the
Dr.
primary
Harikishan.
physician, sir. Sir will be telling more.
Sir, I think your mic is on off.
Yeah. Can you hear me?
Yes, yes. Now we can.
Yeah. So basically, we need to consider this possibility whenever we see a patient with drop in hemoglobin in the absence of overt blood loss. That's when we think of hemolysis. With thrombocytopenia, always keep in mind the possibility of TMA. And so you need to have uh, high index of suspicion. First, you need to consider it for you to work up further. Pregnancy is one setting where we often discuss TMA, HELP syndrome, preeclampsia. Clinically, manifestations are very similar, right? There again, they have hemolysis, there is thrombocytopenia. And we know that pregnancy, there is some, pregnant women are more susceptible to TMAs because there is altered endothelium during pregnancy. The endothelial function is altered during pregnancy. So first thing is to have high index of suspicion for possibility of TMA. The setting could be pregnancy with, HELP syndrome kind of picture, a pregnant woman with thrombocytopenia, or uh, unexplained thrombocytopenia with anemia in the absence of Coombs antibody negative antibodies, where you know that okay, it's not autoimmune hemolytic anemia or Ivan syndrome. Then in the setting of gastroenteritis, we know that sugar toxin related HUS. So the
Yes.
setting it gives us towards etiology. But first thing we need to consider the possibility for which we need to have high index of suspicion.
Yeah. So, have you come across in your experience about such a case where toxin exposure has caused TMA, sir? If you have come across, can you share few of your experiences?
I've not seen any toxin exposure. If at all, this would be my first case.
Yeah.
We did come across TMAs in pregnancy, when the HELP syndrome was not improving
Yes.
postpartum, then we evaluate and then realize that it's actually TTP, which had been undiagnosed till then. Okay,
Yes.
but toxin induced, I've not seen. I guess oncologists probably encounter because most of the drug induced secondary
Drug-related TMAs. Yeah.
TMAs are in the setting of are attributed to some of the antineoplastic agents.
It's like, so very commonly, sir, in transplant setting, we see TTP secondary to cyclosporine and TAC, sir. So in that case, we interchange, sir. If we are using cyclosporine, if he develops TMA, we change to TAC or sirolimus. Or if he developed secondary to TAC. Then we changed to cyclosporin or sirolimus. Like that, we changed and add a mild dose of steroid, 0.5 milligram per kg. They takes time, little 1 or 2 months time for them to improve, but nothing is required. FFP, nothing is required. These are all drug-induced causes of TMA. If you stop that offending drug, automatically they will improve, sir.
Sir, in drug-induced hemolysis, severity won't be this much, sir, so that we can wait.
Yeah, severity will not be there, but there the predominant cell line that will be affected in drug use is platelets, sir. It will be as low as 10,000.
Okay.
So there also we don't give transfuse platelets, just stop the drug and maybe out of desperation we'll give FFP so 1 or 2 days. Slowly they will be improving in next couple of weeks after stopping the drug and change the alternative immune suppression like sirolimus.
Right. Okay, sir. I think we have discussed almost all the points that are pertinent to this case discussion. We had an interesting case discussion today, and I'm just looking at my Q&A box, not finding any questions today asked by the attendees today. And I think if there are no questions, and we have done our closing remarks, I think we can.
Actually, I thought there will be a lot of questions in this case because we have tried FFPs without plaques and all secondary DMS.
You have given a very clear presentation with so much of literature, Dr. Shiva. That's why everybody is clear, I think.
No, it was very difficult to search secondary TMA, the pathophysiology and all those things. Nowhere actually it was given very clearly.
Correct.
It was very difficult.
Okay, so that brings to the end of the session for today's interesting case. And thank you all for taking out your time. And I would like to thank Dr. Harikishan sir and Dr. Ashok Kumar sir for having spent their valuable time and giving their expert opinion on this case taking. And I would like to even congratulate Dr. Shiva for presenting an excellent case today for discussion, which I hope would have benefited to the audience and critical care residents seeing this podcast. So thank you, and we'll meet again on another Tuesday with another interesting topic. Stay tuned to our Tuesday webinars on master classes. Thank you all. Good night.
Thank you. Good night.
Thank you.
Thank you.